Difficult biliary cannulation in ERCP procedures with or without trainee involvement, a comparative study. Introduction. Selective deep cannulation is a critical step for the performance of endoscopic retrograde cholangiopancreatography, ERCP. The incidence of difficult biliary cannulation has been reported in many studies ranging from 10% to 40% in patients with native papilla. Difficult cannulation is an independent risk factor for post-ERCP pancreatitis, PEP. PEP incidence has been reported to be 8% to 12% in patients with difficult cannulation, whereas it is 3% to 5% in patients without difficult cannulation. When the cannulation proves difficult, advanced cannulation techniques are often necessary, including the double guide wire technique, transpancreatic sphincterotomy, or needle knife precut. The European Society of Gastrointestinal Endoscopy has proposed the 5-5-1 criteria for the definition of difficult cannulation. More than 5 minutes spent attempting to cannulate, more than 5 contacts with the papilla to cannulate, more than 1 unintended PD cannulation or opacification. The clear definition of difficult cannulation is important for making decisions during or after ERCP, including determining the appropriate time to transfer to advanced cannulation techniques and whether prophylactic methods should be administered to reduce the risk of PEP. Although the 5-5-1 criteria have been widely used during ERCP practice or in relevant studies, it remains unclear whether these criteria are suitable for cannulation procedures involving trainees. Because of inexperienced manipulation of the scope and accessories, the involvement of trainees generally increases the overall cannulation time and number of cannulation attempts, which are 2 important variables in the criteria of difficult cannulation. Thus, Wang et al. Hypothesized that the definition of difficult cannulation in trainee-involved procedures might be different from the traditional 5-5-1 criteria. To develop the criteria for difficult cannulation in trainee-involved ERCP, the authors retrospectively analyzed the data associated with cannulation procedures with or without trainee involvement. They also compared the proportion of difficult cannulation, PEP incidence, and the frequency of advanced cannulation techniques in patients with predicted difficult cannulation between the proposed criteria in trainee-involved procedures and the traditional 5-5-1 criteria in procedures without trainee involvement. Methods. Patients undergoing biliary cannulation with or without trainee involvement were eligible. Procedures that might be too easy, such as fistula, or too difficult, such as altered anatomy, were excluded. The primary outcome was difficult cannulation, defined as cannulation time, attempts, or inadvertent pancreatic duct (PD) cannulation exceeding the 75th percentile of each variable. Propensity score matching (PSM) analysis was used. Results. After PSM, there were 1,596 patients in each group. Trainee-involved procedures had longer median cannulation time, 7.5 versus 2.0 minutes, and more attempts, 5 versus 2, and inadvertent PD cannulation, 0 versus procedures without trainee involvement. The 15-10 criteria for difficult cannulation were proposed for trainee-involved cannulation, and the 5-5-1 criteria were nearly confirmed for cannulation without trainee involvement. The proportions of difficult cannulation using these respective criteria were 35.5% and 31.8% respectively. Incidence of post-ERCP pancreatitis following difficult cannulation were comparable, 7.8% versus 9.8% respectively. Conclusion. By using the 75th percentiles as cutoffs, the proposed 15-10-2 criteria for difficult cannulation could be appropriate in trainee-involved procedures.